Hello, everyone, and welcome to today's webinar. We're going to give another minute or two for people to join, and we'll be starting momentarily. Hello, everyone, and welcome to today's webinar on waterborne infectious disease burden and recreational water-associated illnesses in the United States. My name is Daisy Galan. I'm a lead analyst at the National Association of County and City Health Officials, NACHO. I'm here with my colleague, Rebecca Rainey, will be your moderators for today. And it is a great pleasure to have our CDC speakers here with us today. Before we get started, just want to go through some logistics. This webinar is being recorded, so afterwards, you're going to receive an email with the link to the recording of this webinar, along with a copy of the slides. So that will be shared to all residents following this webinar later this week, early next week. If you have any questions throughout the webinar, and we hope to make this as interactive as possible, we have built-in time in our agenda for Q&A. So please use the Q&A box. You can add your questions there throughout the presentation, and we'll make sure to have time at the end to go through them. If by any chance we don't get through all the questions, please still put in your question. We will record all questions received, and we'll follow up with our speakers, and we'll share a Q&A summary together with the webinar materials following the webinar. So with that, just to kind of shortly recap our agenda for today, we're going to start with some announcements from NACHO, very short and with a short poll. From there, we're going to go to the main point of today, which is our presentation and our speakers. And then, as I mentioned, we're going to have time at the end for Q&A. So with that, I'm going to pass the floor to my colleague, Rebecca Rainey, so she can share more about our announcements for today.
Hi, everyone. Thank you for joining us. Like Daisy said, I'm just going to share a few new NACHO resources before we turn it over to our speakers. So we wanted to highlight a brand new resource from NACHO that you might be interested in. NACHO has been working for the past year with the Pueblo Department of Public Health and Environment to capture their experience fully adopting and implementing the MAHC into their local code, the Model Aquatic Health Code. And we have a full publication documenting their experience forthcoming in the new year, but we wanted to let you know of one resource that's already live, which is this resource library. So this library contains various resources developed and shared by Pueblo County that they used during their implementation and adoption process. This includes forms, surveys, presentations, and more. So to access this, you'll visit the NACHO toolbox at this link. As a reminder, we'll send out these slides with the link for you to access, and you just need to log in or create a free MyNACHO account to download these resources as a zip file. And then our next resource we wanted to share is our brand new MAHC quick guides. So NACHO released these two MAHC quick guides on splash pads and flotation tanks. These are two topics covered in the Model Aquatic Health Code, and these quick 2 to 3 page reference guides on each subject can be used by health departments, pool operators, etc. as tools for understanding CDC's recommendations for safe operation and maintenance of splash pads and flotation tanks. So these guides combine information from the CDC's 2023 edition of the MAHC and also the website to highlight key takeaways. So you'll just visit this nacho.org/MAHC to view and download those resources. So NACCHO plans to develop more of these resources in the future, and we wanted to hear from you today about what topics you'd be most interested in learning more about. So I am about to open up a poll that should pop up on your Zoom screen. So in this poll, you can select multiple options, and I kindly ask that you just select 3 topics from the list that you are most interested in learning more about through future quick guides, through webinars, or other resources. So I'll open this right now, and I'll keep it open for a few minutes as we transition to our speakers. Great. So with that being said, it is my pleasure to introduce our speakers today. So with us here today from CDC, we have Shauna Miko. Shauna is an epidemiologist for Outbreak Surveillance and Analytics Program Lead for the Waterborne Disease Prevention Branch of the Center for Disease Control and Prevention in Atlanta, Georgia. And Michelle Hulsa is an epidemiologist for healthy swimming and cryptosporidiosis, also in the Waterborne Disease Prevention Branch for the CDC. And so Shauna and Michelle are going to talk to you today about their new research on the burden of waterborne infectious disease by exposure route. And as a reminder, if you have any questions for them, feel free to submit those throughout the presentation, and we'll go through those at the end. So that, I'm going to stop sharing my screen and pass it on to you, Shauna.
Thank you, Rebecca. Can everybody see that? Okay. All right, great. Well, hi, everyone, and thank you all for being here while we share some results from our burden projects, as Rebecca mentioned. So I do come to you from the Waterborne Disease Prevention Branch, which is the lead epi unit for water-related infectious disease at CDC. And I lead the analytics program and outbreak surveillance program in our domestic WASH team, water sanitation and hygiene. So for my portion of the presentation today, I'm going to review the evolution of burden work, as well as the results from burden 1.0 and 2.0, and what we hope is coming next. So let me take you back to the beginning of that landmark study that started it all, the first burden of waterborne disease paper. So that first paper was born from the acknowledgement that there was an outdated perception of waterborne disease. In the US, not only are cases of cholera and typhoid rare now, but outbreaks associated with large public drinking systems have sharply declined in the last about 40, 50 years. So however, transmission of disease via drinking water systems still occur, and that's often attributable to aging infrastructure, operational challenges, and private or unregulated systems like wells that serve about 45 million people. Moreover, our mostly safe and mostly reliable water supply has led to increasing use of water in complex ways, which I'm sure many of y'all are familiar with. We have complicated plumbing, heating, and cooling systems in large buildings, including buildings that house sick people like hospitals. We use water as an integral part of the food production process. We rely on water for lots of medical uses, including dialysis and ventilators. And I don't have to tell you that people are finding more time to swim in increasingly complicated recreational water venues. So there's this outdated belief of waterborne disease, and the existing research really focused on drinking water and gastrointestinal illness. So naturally, the only logical solution in our minds was to estimate the burden of waterborne disease. And this made sense because historically, the estimates of burden of foodborne disease in the US have been really useful in directing prevention activities and setting public health goals. So we thought quantifying the burden of infectious waterborne disease in the US would also be beneficial. So let's walk through a high-level description of the process of how to do this. Our division colleagues, led by Elaine Scallon and Mike Hoekstra, published an enormously influential foodborne estimate in 2011, and we based our approach on the methods that they had developed. So for our estimate, we focused on the acute effects of waterborne associated infectious disease, and we defined waterborne disease as a disease in which water was the proximate vehicle for exposure to an infectious pathogen. But that means we didn't include chemical exposure, algal toxins, or diseases like malaria where water was the reservoir. We chose diseases for which there was surveillance data, administrative data, or literature reports that indicated that waterborne transmission for the disease in the US was plausible, and that the disease was likely to cause substantial illness or even death, and also where data were available to quantify the associated health outcomes. Ultimately, we ended up with these 17 diseases. So from there, we chose to look at 5 outcomes: illnesses, emergency department visits, hospitalizations, deaths, and direct costs. We use disease surveillance as the basis for our estimate, but it isn't as simple as counting one surveillance report as one case. So if you think about a person who gets sick with a disease, several things need to happen for their illness to be reported into a surveillance system. This is one of the biggest advances made by Scallon and Hoekstra and colleagues, is that they had actual data from prior studies for each step in the progression from a person becoming ill to becoming a reported case. So to clarify this, I'll use CAMPI as an example. So research shows that roughly 18% of those with CAMPI seek care. And that makes sense since many healthy adults don't usually seek care for diarrhea, and CAMPI usually resolves on its own. Of those 18%, we know that only 19% get their stool sample sent for testing. And again, most providers aren't going to send stool because it's diarrhea and it'll resolve, drink plenty of fluids, etc. Among those that submitted samples, 97% will be tested for CAMPI. And of those that are tested, we know that the test has a sensitivity of 70%. So all of that ends up meaning that if 100% of positive CAMPI tests are reported as cases, we can infer that every reported case represents roughly 43 actual cases. Now we take that observed lab-confirmed illnesses from reporting sites over several years, apply some math, and we end up with a mean estimate of the domestically acquired illnesses. The rest is really for a statistician to explain, but I'll try to break it down a little bit. We use available literature to examine reported illnesses, and then we use multipliers to correct for the underreporting and the underdiagnosis. And then we used estimates for domestically acquired versus acquired abroad, and the proportion that would be transmitted through water to get those estimates. And that sounds oversimplified, as if we just did a bunch of multiplication, but each multiplier was generated independently in a mathematical model using 100,000 iterations. So to doing that, we obtained distributions of counts and used them to generate these estimates, and then means and corresponding confidence intervals and uncertainty intervals. And then we, in the end, got distributions to account for low, high, and midpoint estimates for all 17 pathogens and illnesses. So the hard work did pay off, and those estimates were published in 2021 by Collier and colleagues. And for those of you who aren't familiar, I'll briefly review the results. We found that over 7 million cases, including 600,000 emergency department visits, 120,000 hospital stays, and 7,000 deaths each year, resulted in $3.3 billion in direct healthcare costs due to waterborne disease every year in the US. And some additional numbers that y'all might be interested in is that among those 7.2 million cases, the majority were otitis externa, followed by illnesses caused by norovirus, giardiasis, and crypto. Among those 600,000 emergency department visits, most were due to otitis externa, but more serious health outcomes and direct costs were heavily impacted by biofilm-associated illnesses. For anyone not familiar with the term biofilm, a biofilm is a group of microorganisms, often a mix of bacteria, fungi, and amoebas that live together, and they release this slimy, gluey gelatin matrix, and that allows them to stick to surfaces. And that slimy home also acts as a barrier to water treatment chemicals like chlorine, helping them survive and multiply. Biofilms are more likely to grow abundantly in places where water doesn't move much, like inner surfaces of water pipes, water storage tanks, or even water heaters. For the purpose of the burden analysis, we considered 4 diseases to be biofilm associated: non-tuberculous mycobacteria, Legionnaires, Pseudomonas pneumonia, and Pseudomonas septicemia. We know biofilm-associated pathogens can have more severe consequences in those with weakened immune systems. And we know that non-tuberculous mycobacteria and Legionnaires can result in recurring infections in up to 50% of patients. And we know that Pseudomonas infections can be multi-drug resistant. And of course, rare amoebic infections have a high mortality rate. But this paper also reports that annually, 70% of those hospitalizations, 94% of deaths, and 78% of costs were due to biofilm-associated waterborne disease. So, Burden 1.0, it was huge publication, huge success, and it resulted in extensive communications and partner outreach efforts, which galvanized the attention in the waterborne research community. But we wanted to take these results further and quantify exposure-specific diseases from 3 water sources: recreational water, drinking water, and non-rec non-drinking water. How does one go about estimating how much waterborne disease could be attributed to each of these 3 types of waters? With a little help from friends, of course, or a lot of help rather. So around 2017, our colleagues from University of Florida and CDC conducted a structured expert judgment study using 48 experts to estimate the proportion of diseases attributable to 5 major transmission pathways: foodborne, waterborne, person-to-person, animal contact, and environmental. And for waterborne, they used subpathways, including recreational, drinking, and non-rec non-drinking. They defined the water subpathways a bit more broadly than the categories we use in NORS, if y'all are familiar with the National Outbreak Reporting System, but they're still quite similar. So you can see that rec water encompasses treated and untreated water. So you have your pools, splash pads, even things domestically like your slip-in slides and lakes, etc. Drinking water is that piped water that's typically used for drinking, but other uses. And then the non-rec non-drinking water is a lot of industrial water, ag water, and medical water. So they did estimates for 33 pathogens with those experts, including 17 pathogens from the first burden paper. Now, thinking back, remember all that math that we did to estimate the counts and credible intervals for that first burden paper? we take each one of those mean estimates from that first paper for each of the 5 outcomes and all of the 17 pathogens. And then we pull in the proportion estimates and their credible intervals from the Bashir's structured expert judgment paper. And then we do the observations in each data set, we multiply them, and we produce another 100,000 observation data set that contains the estimated annual number of cases transmitted through each of these 3 water types. Again, not a simple multiplication, and the rest is for a statistician to explain, but eventually the paper came out thanks to an amazing team. So I'll briefly review the results for drinking water, and Michelle will review the results for the rec water. For this attribution analysis, we found that among those 7 million waterborne infections from the first burden paper, a little over 1 million, or almost 20%, were linked to drinking water. And in those 1 million drinking water illnesses, more than half, or 600,000, were attributed to norovirus. Giardiasis was linked to about 12%, and then that large blue wedge of others is mostly comprised of CAMPI, crypto, NTM, or the non-tuberculous mycobacterium, and non-typhoidal salmonellosis. Of those 600,000 waterborne related ED visits from the first burden paper, drinking water was linked to only 5%, or 32,000 visits. For those drinking water associated visits, 48%, or almost half, 15,000 cases, were linked to otitis externa. And then 38%, or 12,000 cases, with norovirus, and 11% with the non-tuberculous mycobacterium. Hospitalizations is where we start to see drinking water having a larger impact on the burden than rec water, where 40%, or 48,000 hospitalizations, were linked to drinking water exposure. And nearly 3/4 of those were non-tuberculous mycobacterium infections, followed by Legionnaires and norovirus. And when it comes to waterborne infection deaths, rec water was linked to the least amount, and drinking water was responsible for 3,300 deaths, or 50%. And NTM infections, again, accounted for 78% of those deaths, followed by Legionella. And finally, for those direct costs, the $3.3 billion, drinking water was associated with $1.4 billion in hospital visit and stay costs. That's 40% of that over $3 billion in direct costs associated with drinking water exposure. And 3 types of illnesses accounted for 3/4 of that $3 billion. The NTM infections with 46%, the Pseudomonas pneumonia, and then the Legionella, all biofilm pathogens. So you can see that we're seeing a lot of infectious waterborne disease burden in the US. Overall, the percentage of biofilm-associated diseases and impacts rise with the more severe outcomes. So before I leave you, I want to mention our next steps. With Burden 2.0, we have the first of its kind attribution, assigning burden to each of these water types. But some of y'all may have noticed that it lacks some important results. And we want to take this to the next level and understand how these results are affecting communities differently, so we can better focus our recommendations and funding so that all persons in the US have access to safe water. So stay tuned. And in closing, I just want to say that good collaborators are almost as necessary in life as clean water. So in addition to the co-authors like Michelle, who you're about to hear from next, these are just some of the many people who helped this project move forward, and we're truly grateful for their assistance. Thank you for your time. And Michelle, if you're ready, I will turn it over to you. Up next is Michelle Avalsa, which I think many of you are familiar with, and she leads our recreational water and healthy swimming program in our Food, Water, and Environmental Diseases Division.
Thank you, Shauna. Let me just see if I can just get under there and just share my slides. Okay. All right, let's see. Here we go. All right. So thank you, Shauna. And I'm going to start where you left off, Shauna. And first, I'm going to go with acknowledgements. And first, I want to acknowledge you. What a great presentation. And a lot of the slides that I'll present up front are from you. So thank you for that. And most of all, I think I need to thank you for really being one of the big forces that pushed that Burden 2.0 paper over the finish line, got that analysis done and got that paper out and provided us with this opportunity to share data with our public health colleagues as well as with aquatics here on today's webinar. I also want to thank Joe Lako, CDC and National Center for Environmental Health colleague who along with his leadership helped helps fund this webinar series, this opportunity to share this information through NACCHO, and specifically at NACCHO I want to thank Daisy Gallen and Rebecca Rainey. But I think the people I need to thank the most might have to be the harmonization committee, the committee looking at harmonizing the Model Aquatic Health Code, or the MAHC, and the International Swimming Pool and Spa Code, or the ISPSC. On the MAHC side of the house, Joe Lako and Dewey Case over at the Council for the Model Aquatic Health Code, the technical director there, represent the MAHC, and over at PHTA, Joe Lorino and Greg Seaton representing the ISPSC, and that's over at the Pool and Hot Tub Alliance. Okay, so what do the annual national estimates for recreational water associated infections look like in the United States? So as Shauna had mentioned earlier, there are some 7.2 million waterborne infections in the U.S. Each year. About 80% or 5.6 million of those are associated with recreational water, or rec water. If we drill down into rec water further, we see that almost 80% of recreational water associated infections are swimmer's ear, or as Shauna said, acute otitis externa. These 4.4 million cases of swimmer's ear were associated with rec water. They represent about 62% or almost 2/3 of all waterborne infections. When we look at emergency department visits for waterborne infection, we're looking at some 601,000 emergency department visits for waterborne infections. 92% or 552,000 of these ED visits are associated with rec water associated infections, or the result of recreational water associated infections. If we drill down further, we see that 97% of emergency department visits for recreational water associated infections are the result of a case of swimmer's ear. These 538,000 ED visits for swimmer's ear associated with recreational water represent 90% of ED visits for all waterborne infections. If we look at hospitalizations, we saw almost 120,000 hospitalizations occurring in the U.S. each year for waterborne infections. This is about 36% or 42,300 hospitalizations for recreational water associated infections. Drilling down, we see just over half, or 52% of hospitalizations for recreational water associated infections being the result of swimmer's ear. These 22,000 hospitalizations for swimmer's ear, are associated with recreational water. So if we look at that overall, that's about 20% of hospitalizations for all waterborne infections. When we look at waterborne infections leading to death, there are some 6,630 of those each year in the United States, almost 20% or 1,290 caused by recreational water associated infections. If we look at that further, we see that 16% of deaths are caused by recreational water associated infections being cases of a swimmer's ear. These 208 deaths caused by swimmer's ear associated with recreational water represent 3% of deaths caused by all waterborne infections. If we look at direct costs of waterborne infections, and by this I mean visits to the emergency department and hospitalizations, as Shauna said, we spend about $3.3 billion a year that way. Almost 33% of that, or $1.07 billion, is direct cost for ED visits and hospitalizations for recreational water associated infections. Drilling down, we see about 50% of that cost being ED visits and hospitalizations for recreational water associated infections when those are cases of swimmer's ear. The $536 million spent on hospitalizations and ED visits for swimmer's ear associated with recreational water represents 16% of direct costs for ED visits and hospitalizations overall. So what is the take-home message of these data in terms of aquatics and healthy swimming? When I was at the World Aquatic Health Conference in Las Vegas last month, I heard a rumor that, well, swimmer's ear, it's now the new big issue in aquatics. It's the most important issue to be addressed in aquatics. But in looking at the data, I'm not sure I agree. I would say, hold on, we need to take a step back and really look at what's going on. What is this thing called swimmer's ear or otitis externa, and is it the leading cause? Is it the leading issue that needs to be addressed by aquatics? So I hope in the next slides I convince you that it's probably not the most important issue that aquatics needs to address. So when we think swimmer's ear, we think Pseudomonas. Pseudomonas is by far the leading cause of swimmer's ear. Swimmer's ear is also caused by Staph aureus. It is found in the environment. It is transmitted through contact with contaminated water. So there are other conditions Pseudomonas causes, such as hot tub rash, and hot tub rash, also known as folliculitis, is when we develop an infection, the shape of our swimsuit, our bathing suit. That suit holds that contaminated water on our skin, and about 36 hours later, we have a rash the shape of our bathing suit. Pseudomonas can also cause hot hand-foot syndrome. This is basically pain and swelling, sometimes nodules even in the palms of our hands and in the soles of our feet. Now, Pseudomonas, whether it's causing swimmer's ear, hot tub rash, or hot hand-foot syndrome, regardless of what it's causing, we really shouldn't be seeing these cases associated with recreational water, specifically treated recreational water. Pseudomonas is readily inactivated by disinfectants, meaning that the minimum disinfection concentration that CDC recommends, which starts at 1.0 parts per million free chlorine in the water, prevents waterborne transmission. And the same can be said, most of our local, state, territorial, and tribal public health partners are requiring at least 1 part per million free chlorine. So at that point, we shouldn't be seeing transmission of Pseudomonas and most other pathogens. However, if we dip below that minimum disinfection concentration, if we're not maintaining that minimum there, Pseudomonas is going to grow. It's going to replicate. It's going to amplify. It's just going to take off in that water. And the surfaces. And it does so in the surfaces, as Shauna mentioned, in the biofilm. And the biofilm, when the chlorine level is down, is going to build up. And it's going to build up and build up to the point where it's going to be able to protect the pathogens within the biofilm from disinfectants, even when the disinfection level is where we need it to be. And that's why we see these outbreaks caused by Pseudomonas with hot tubs when the disinfection concentration is bouncing between 0 and adequate disinfection and back and forth between inadequate and adequate situation. We have biofilm building up and Pseudomonas growing within that biofilm, waiting for that concentration to go back down. Before I get too far into swimmer's ear in terms of signs and symptoms, I do want to give a quick anatomy lesson for the ear. So what we're looking at here in this figure is the outer ear, middle ear, and the inner ear. So the outer ear, what we're going to focus on when we're talking about swimmer's ear or otitis externa, we're talking about the part of the ear we can see, which includes the pinna, and it also includes the ear canal. The ear canal is going to be covered by a layer of wax. That layer of wax helps prevent infection. It's got antimicrobial properties, and under that is going to be skin. And so when we're talking about otitis externa, we're talking about an infection anywhere in the outer ear. So the part of the ear we see, as well as the ear canal. And when patients have a swimmer's ear, they experience a lot of pain. The pain is usually described in the scientific literature as exquisite, so pretty intense. And the pain can occur when we tug on the outer ear, so that when we pull on the pinna here, the part of the ear we can see, or when we put pressure on the tragus, or the part of the outer ear that sticks out in front of that ear canal, that part you can hold down and it kind of plugs up that part of the ear canal that opens up to the outside. Patients with swimmer's ear describe an itchiness inside the ear or fullness inside the ear. They often have drainage coming from the ear, and there's redness and swelling in that ear. And you know, when the clinician, when the healthcare provider looks in, they can see that redness and swelling here along the ear canal. In terms of preventing swimmer's ear, this is something the public can pretty much do by themselves, or if the swimmers aren't doing it themselves, then the parents of young swimmers can help them. So first of all, it's about keeping the ears as dry as possible. So keeping the water out of the ears, to begin with, using a bathing cap. I know everybody looks really good in those. Earplugs or custom fitted swim molds in the water, especially if you're going to deeper depths of water. You want to keep the ears, you want to dry the ears, thoroughly after being in the water. And you can use a towel to dry the ears as well. And then we do that. I just got out of the water dance to get that water out. We're tilting our head back and forth so that the ear faces down and the water can escape the ear canal. We sometimes pull on the pinna or on the earlobe in different directions, trying to straighten out that ear canal and allowing the water to drain better. If these tricks don't work, CDC recommends possibly using a hair dryer to move the air within the ear canal. So you're going to put the hair dryer on the lowest heat setting, lowest fan setting or speed setting, and you're going to hold that hair dryer several inches from the ear. We don't want to burn the ear. We just want to get air moving in that ear canal, get that water dried up. Oop. Sorry about that. In terms of other steps we can take for preventing swimmer's ear, it's consulting with the healthcare provider. If we're not keeping the water out, or we're having a hard time getting that water out, or drying that water out, patients can go to their healthcare provider and get ear drying drops to put into their ears after being in the water. These drops are not recommended if you have ear tubes or tympanostomy tubes, which is just basically a tube that runs through the eardrum. If the eardrum is punctured or ruptured, if you have swimmer's ear or ear drainage, basically what you're trying to do is you don't want to use these drops in these situations, because you don't want infection moving on either side of that eardrum, moving from the again from either side of the eardrum. We also want to make sure that if we're feeling itchiness in the ear, or we want to get rid of some wax, we're not putting objects in our ears. We don't want to scrape that wax away. We don't want to injure the skin. We shouldn't be putting cotton tip swabs, pencils, paper clips, or keys in our ears. And we should, if we think we've got like a blocked ear, like impacted earwax, we shouldn't be trying to remove that. If that's what you think you have, check with your healthcare provider. In terms of treating swimmer's ear, there is clinical guidance out there, practice guidelines. And basically, it's about topical treatment or putting eardrops in the ear. We're just going to put our antimicrobials, our antibiotics, right where that infection is. In actual practice, we're seeing that oftentimes healthcare providers are prescribing oral antibiotics or antimicrobials. And that's what we call systemic treatment. So we're going to swallow a pill or a suspension, a liquid form of the medication, and that antibiotic or antimicrobial, it's not only going to go to the ears where that infection is, it's going to go throughout our different parts of our body, and it's potentially going to expose other bacteria in the body and create what we call antibiotic resistance, where the antibiotics don't work against that bacteria anymore. And so what we're trying to do here at CDC is to work with healthcare providers to make sure we're only giving these oral antimicrobials, these pills, the liquid medication, only when it's actually needed. So, you know, for most people, all you need is eardrops. If you have a weakened immune system, if you are diabetic, oral medication might be right, but that doesn't happen very often, that the oral medication being called for. So actually, we see that that treating with oral antimicrobials varies with specialty. We see about 20% of pediatricians giving about 27% of their swimmer's ear patients oral antibiotics, while we see about 47% of clinicians in the emergency department giving oral antibiotics. It could be that in the emergency departments, the infection's a bit more severe and more painful, so people go to the emergency department. However, we'd like to see those percentages come down. And finally, why we don't think that swimmer's ear needs to be addressed by aquatics is because aquatics has already addressed a swimmer's ear. It's addressed it in the codes, whether we're talking about the MAHC or the ISPSC. In terms of the MAHC 5731, which addresses primary disinfectants, calls for maintaining free chlorine at least 1 part per million when we're not using cyanuric acid in most aquatic venues. So remember, cyanuric acid, it binds to the free chlorine so that it's not degraded by the ultraviolet light from the sun, but it's also going to slow down the disinfection rate. So if we're going to have cyanuric acid in the water, the minimum is 2 parts per million free chlorine in most aquatic venues. However, when it comes to hot tubs, we want a minimum of 3.0 parts per million free chlorine. And that's because the water temperature is higher. We're aerosolizing the water, and we want a higher minimum disinfectant level to make sure that we're keeping that disinfectant concentration where it needs to be. You know, when multiple people get in the water, whatever the case may be, we just want to make sure we're not transmitting pathogens like Pseudomonas. MAHC 5734 addresses pH and calls for maintaining the pH at 7.0 to 7.8, and that's primarily to make sure that the free chlorine is effectively killing pathogens or inactivating pathogens like Pseudomonas, but also that the swimmers are comfortable in the water and the equipment's not getting corroded. MAHC 6.1 talks about qualified operator training and calls for training operators on water quality. And we know from multiple publications that the water quality, the pH, the free chlorine are more likely to be in proper range when we've had trained operators. And MAHC 64131 calls for daily inspection before opening. So one of the items is inspecting for, and if needed, removing biofilm. So getting rid of that layer of that polysaccharide mix that protects, you know, the Pseudomonas and other microbes from the disinfectant. So what really is a take-home message? In my mind, it's about public health taking the lead on efforts to address swimmer's ear. It's about contributing to research, getting data that helps us optimize prevention efforts. Back in 2011, we put out an MMWR, probably one of the earlier burden efforts here in the waterborne disease prevention branch, where we looked specifically at acute otitis externa, specifically swimmer's ear, as we've been referring it to in this presentation. And coming out later this year, the state of Maine is putting out an MMWR looking at an outbreak associated with a hotel pool, and this outbreak was caused by Pseudomonas. So, you know, not only doing like studies, but being on the front line and sharing experiences from outbreak investigations. Public health, like I mentioned, needs to educate the public about prevention. Public health also needs to educate providers about properly treating swimmer's ear. Aquatics needs to be aware of what steps it can take to prevent swimmer's ear. And that can happen in workshops before the summer swim season, or that can happen during inspections where we're not only enforcing codes that protect the public and potentially help prevent swimmer's ear, but also educating operators. The numbers here have a few limitations. The data are from 2014, so things have changed the way we diagnose and the cost of items, for example. We've only covered 17 diseases in the data we've presented, and you know, there are other diseases that are caused by transmission through water, and we didn't get into chemicals and the illnesses that they cause. For example, toxins from harmful algal blooms. The diagnoses in the data sets used were from for reimbursement from insurance companies, Medicare, Medicaid, private insurance. So what the clinician or healthcare provider saw might not actually be the way he or she would describe is happening to the patient, what's going on with the patient. And for recreational water, we didn't differentiate between treated water, so chlorinated filtered water in pools, hot tubs, and splash pads versus untreated water, so water that isn't filtered or chemically treated, such as in lakes and rivers and oceans. And that's it for me. And here's an example of a fact sheet we have for swimmer's ear. Thank you.
Thank you so much, Michelle and Shauna, for your wonderful and great presentations. A lot of things for us to reflect. So we see here several questions in our Q&A box. So feel free to continue adding your questions here. Due to the size of this webinar, we're not going to open up for verbal questions. So I know I do see some hands up. So if you could please add your questions or comments in the Q&A box. They are all welcome. So I know a lot of the questions have already been answered here through our speakers. We'll start with one question which Sean, I do see already addressed here in the Q&A box, but just to clarify for the audience, you or Michelle. So can you speak about other deaths attributed to waterborne recreational exposure, infections with Pseudomonas and NTM infection, seem more important for hospitalizations and deaths data?
And to clarify, Daisy, was that for recreational water or all waters? The question.
The question was attributed to waterborne and recreational exposures.
I can let Michelle, of course, speak for rec water. She is the subject matter expert for that one. But yes, we are seeing that those more serious implications, such as hospitalizations, deaths, and a large portion of those costs are attributable to Pseudomonas and non-tuberculous mycobacterium and Legionella, those biofilm-associated pathogens. And I think I responded to that question, and thank you so much for linking the papers into the general chat. Table 4 of the Burden 2.0 paper, the Gertis paper, will definitely have those specific breakdowns of the diseases and syndromes, and from rec water, drinking water, and non-rec. But I will kick it over to Michelle.
Yeah, I would just echo what Shauna presented when she talked about in her presentation, that when we're talking about, you know, the number of cases, when we're talking about emergency department visits, that's where recreational water tends to dominate. That's where swimmer ear dominates. But as we get into more severe outcomes, the hospitalizations, the deaths, that's when other things come into play, the Pseudomonas pneumonia, the non-tuberculous mycobacterium. So when I think non-tuberculous mycobacterium, I think of hot tub lung. I think, you know, there have been examples that we've seen where people are pressure washing cartridge filters from hot tubs, and you know, they get sick, and then on their x-ray it looks like broken glass. I mean, that's going to be a lot more serious than an infection in the ear, and again, like Pseudomonas pneumonia is going to be much more serious. Being on pneumonia sometimes means being put on a ventilator, so you know, definite hospitalization there, and definitely more serious. I think the cost for swimmer's ear is more about the ED visits. It's not about the hospitalizations.
Okay, thank you both. So our next question we'll have you answer is, we had an individual ask if there were any health hazards associated with inhaling chlorine, so e.g. higher concentrations in hot tubs.
So the data presented here by Shauna and myself focused on infectious disease. It didn't get into exposures to chemicals, but yes, there are issues to being exposed to gaseous chlorine. We've seen outbreaks where the recirculation system in a pool shuts down and the chemical feeders continue running. So concentrated chlorine and acid are mixing, which generate toxic chlorine gas. Typically, when the recirculation system is running, we're mixing chlorine and acid in a diluted form, so we're not creating toxic chlorine gas. But if it happens that the recirculation shuts down and we end up generating toxic chlorine gas because we're mixing concentrated chlorine and acid, and then we restart the recirculation system, we've seen the release of toxic chlorine gas, and we've seen outbreaks where tens or scores or, you know, of people are negatively impacted, where, you know, the hazmat team is coming in, multiple ambulances are coming in, overnight hospital stays, overwhelmed emergency departments, etc.
Thank you, Michelle. So the next question asks about, does Pseudomonas have a baseline for non-treated natural water bodies used for swimming similar to E. coli?
Was the question, is there a baseline for untreated waters for Pseudomonas? I'm not aware of the baseline. The only data I've seen come from EPA in terms of coastal waters has been based on Enterococcus and E. coli.
I can speak, and there are specific strains of Pseudomonas, like Pseudomonas A, that are not uncommon to find in freshwater bodies.
Great. So our next question is, are there any changes yet to water treatment standards in light of these findings?
Not for pools, but for Shauna, do you want to go ahead?
For the water, oh, I thought it was, I'm sorry, I thought it was a rec water question. I apologize. So EPA is taking a lot of this information under advisement as they continually meet and update their what is included on the list for the drinking water regulations. There are a few changes in the works, but I would defer to Michelle for MAHC and pools. She is the leading expert on that.
Yeah, it's like I mentioned at the end of the talk in terms of Pseudomonas and other pathogens that are readily inactivated by chlorine. We shouldn't be having those issues. Those issues have been addressed by maintaining proper free chlorine, maintaining the proper total bromine, maintaining proper pH, making sure we're checking and removing biofilm. So all that's already in the MAHC and standard practice for the most part.
And then kicking back over to drinking water. So, you know, I mentioned a lot about NTMs, the non-tuberculous mycobacterium. That is not nationally notifiable. But it's something that, you know, we have a dream of one day being notifiable and being able to have a surveillance system for that. So we're hoping that research like this and future research will continue to shine a light that I think EPA is certainly recognizing that biofilm pathogens are becoming a more prominent issue, especially in our drinking water distribution systems, and that we could use more surveillance systems and more funding, more understanding on how to combat them safely.
Thank you. So our next question here is about crypto, and it's asking about, you know, did the analysis consider the spread from swimming pool into childcare facilities has related to recreational water use? Several large outbreaks in the past had dozens of cases directly from the pool, but hundreds of cases associated with the spread into childcare settings.
So Pseudomonas isn't something we really see spread person to person. It is transmitted by water. So the difference between crypto and Pseudomonas is, you know, crypto is very extremely tolerant to chlorine. So we can easily see it go from pool to pool, where chlorine is a primary barrier. And then we have bleach solutions in daycare where again, chlorine is a primary barrier to transmission. So it's not surprising that crypto goes pool to pool, and then, you know, it goes into daycares. Who do we see at the pool on the weekend? It's the little less than 5-year-olds. So that's how we see that. In terms of Pseudomonas, you could bring Pseudomonas from one pool to another. If that pool's well maintained, it's not going to spread, and it's not going to spread to daycares if we're maintaining our daycares well either.
And I'll just add on that for this analysis specifically, like Michelle said, because we used administrative data, we used insurance reimbursement data, Medicare and Medicaid. So whatever was on that ED visit chart or hospital visit chart, that's kind of one of the limitations. That's what we had to go by. So if it was a child that was in a daycare that got it from a child that got it from a pool, if it's not necessarily in the medical chart, we can't account for that. But that would be a very interesting multiplier for correction for future studies.
Great, we'll do one more question and then wrap up. And like we mentioned, any questions that weren't answered today, we'll make note of and pass along to the speakers. So our last question is, what is the trick to get bathers to shower properly before entering pools or maybe other aquatic facilities?
I think you automatically, you gotta sneak that shower in on them somehow. Maybe like a car wash option, you know, like they can't get to the pool unless they get hosed down. And I guess, I don't know. Joe, do you have anything to say on that? I don't know how you trick people.
Yeah, that's changing human behavior is going to be really the tough part, because the bathers are another part of the equation of all this and how safe pool water is. And people regularly shower before entering pools in Europe all the time. In the US, you rarely see that, but I think it would definitely be helpful to reducing the risk in pools. How we do that, that's a tough one.
Well, we're right at time, so I want to be thankful to everyone for participating, also respectful of everyone's time, our panelists and also our attendees. So as Rebecca mentioned, we are keeping track of all the questions here, and we'll put together a summary of the Q&A, including the questions that were answered via the Q&A box so that it can be easily accessed. Together with the materials from this webinar, you're going to receive the links for all the different articles and papers that were mentioned in studies throughout here, and any additional resources that our speakers have to share with this audience. We really want to thank everyone again for attending. If you have any additional questions for our speakers, please feel free to reach out to us. We conduct this webinar on a quarterly basis. Our next webinar will be in February of next year around that time. So please keep an eye for it. If you don't receive our newsletter, please go to our website, sign up. And we have several webinars on demand. You can watch those and also find our resources there. Thank you again for Shauna and Michelle, and also Joe for being here with us today. It was a pleasure, and we look forward to having you guys in our next webinars. Have a great day, everybody.